very interested in pursuing this thing because as we know, the spine surgery is going more and more ambulatory and people are getting discharged the same day. So to understand this, there are a few things that we need to understand how the body reacts to surgery. It doesn't matter what kind of surgery it is, whether it's an abdominal thoracic surgery or the back surgery. So the body goes through three phases. One is the shock phase, catabolic phase, and the convulsion phase. The shock phase is very rare after surgery, and the catabolic phase. So body deals everything like a trauma. Once there is some trauma or some incision done in the body, it tries to mobilize all kinds of resources. It wants to hold on to water, sodium. It wants to break down the protein so that it can get more raw materials to build whatever it needs to build, and also gluconeogenesis. And this happens initially after the surgery, and at the end of this usually it retains more water and sodium, and this is followed by the convulsion phase, where now the body realizes that the acute phase is over, now that it can come back to its normal state, where it has to get rid of all the sodium and the water that has been accumulated and starts to build proteins and starts to build glycogen after that. And so after that thing, the next concept is volume obligator. This was first proposed by Claude Bernard, which means that, I'll just read it out, if there is sufficient fluid intake or administered to balance insensible or other losses and to meet the kidney's needs, there is no advantage of giving additional excessive volumes. So what body does is, when urine output and concentration change, accordingly to achieve the volume that needs to be retained in the body. And kidney is very, very efficient in conserving as much amount of water and sodium when it needs to, but however it is not that good and it's not that efficient to excrete the same amount of sodium and water. So let me go over the small question. This table, where if you look at the parameters here, the sodium is in normal saline, the sodium is slightly higher than the usual sodium, and then if you look at the chloride, it's about 154, and the normal plasma chlorine is about 95 to 105, which is like almost 33% higher, which comes down here the pH. The pH is significantly lower for a normal saline, which is about 4.5 to 7. Usually it comes around 5.5. So what happens if you are infusing post-operatively normal saline to any person, already the person is accumulating acid due to like a lactic acid or like a side metabolite of several things. You're giving more acid and it's not helping him recover better. And the other thing that is important is, during the medical school, everybody emphasized that whatever the fluid that you give, only 33% of it gets retained in the body, in the intravascular volume, and the rest of it is in the interstitial. But in reality, only about 25% goes to the intravascular volume. If you look at the Hartmann solution or the normal saline, to increase 1 liter of plasma volume, you'll have to give like 4,000 to 5,000 cc's, which means that only 3 to 4,000 goes to the interstitial and only 1 liter stays back in the intravascular volume. So what we need to understand here is our goals for enhanced recovery would be to reduce the post-operative pain and prevent nausea, vomiting, which is very important because the patient can start eating and feeding himself and drinking, hemodynamic optimization and reduced blood transfusion. So this requires a multidisciplinary approach, which I will come to it. So it needs to educate the spine surgeon, the anesthesiologist, the nurse practitioner, the pre and post-operating nurse to manage these things, and the early physical therapy and post-operatively discharge management once again comes mostly on the nurse practitioner in the clinic. So on pre-admission, it is very important to realize that the discharge planning starts at the time of admission, and there are a few things that we usually advise our patients, usually to eliminate the tobacco, walk for 30 minutes, like probably at least for a week before. A lot of spine patients are in like a lot of pain even before the surgery, and it might not be possible. We do encourage them to walk as much as possible before the surgery, so their body is accustomed to some kind of an exercise. Use of incentive parameter before and after surgery, so the lungs know how to expand pretty well, and wash with Hiboclens the previous night reduces post-operative infection. Explain the patient that recovery happens with their participation. It doesn't happen when they're just sitting down and the body just takes care of everything. So pre-admission, what do we need to do? Protein supplement. This increases the immune response of the body. And hydrate with clear carbohydrate fluid. The American Association of Anesthesiologists have specified clearly that a non-residual carbohydrate fluid can be given up to 2 hours right before the surgery. This helps for the patient to reduce the thirst, hunger, anxiety, and in addition, post-operatively, due to a prolonged starving, there is some gluconeogenesis, and this increase in glucose in the blood is very difficult to bring down and leads to some amount of transient insulin resistance, and we can avoid all those things. This clear fast was actually devised by, I think, the Duke group of anesthesiologists, and then most of the places, the surgical centers, they use just the Gatorade thirst quencher. And at the time of admission, like about an hour before, Tylenol per mouth, and then Zofran to prevent post-operative nausea and vomiting just before they start waking up. And scopolamine has only been used on patients who have had a previous episode of like significant nausea after surgery, and some of them have even opted to give Decadron 4 to 6 milligrams at the beginning of surgery. So why am I emphasizing so much on the post-operative fluid management is, if you look at the curve, the complications on the Y and the volume status on the X, so the optimal fluid has the minimal amount of complication, while there's hypo and hypervolemic has significant higher amount of complications. And so the goal of perioperative therapy is to prevent hypotension and to manage tissue perfusion with good oxygen delivery. And we usually prefer maintenance fluids as 1 to 1.5 cc per kg per hour. Ringer lactate is definitely preferred because it is more closer to the plasma, and urine output to be replaced accordingly 1:1, and so is the blood loss. And a lot of patients, a lot of hospitals also measure the patient's body weight to make sure that they're not accumulating more fluid, which eventually transforms to elevation in body weight. And more than 5 pounds have been noted to increase in the length of stay. Resuscitation, once again, ringer lactates. I'll come to one more. The only time we use normal saline would when there is a hyperkalemia, which is one of the side effects that as the patient comes out. So replacement and maintenance plus ongoing loss, and maintenance is usually 25 to 35 cc of free water. So this is one of the common charts that everybody uses after surgery, and it is a part of the enhanced recovery after surgery, which we well known as ERAS. If you find oliguria, just make sure whether the patient is really hypovolemic or there is a vasodilation response to anesthesia or any other medication. If there is a really hypovolemia that is established based on all these parameters, so go ahead and give the fluid, and if they are responsive, then you can if they're responsive, you can continue the maintenance fluids. If they're not responsive, you can try a shot of diuretics and see. And if they are not known to have any hypovolemia, one of the responses of the body is to hold on to water and sodium, like I mentioned before. That might be part of it, but even if there is hypoglycemia, even if there is hypovolemia, or so it might be an outflow obstruction. So the best way to measure hypovolemia is to measure the stroke volume, and to measure the stroke volume variation, which is one of the common ways to decide how the patient responds to fluid, and this is done in several ways. So what we commonly use in interpretation, what we commonly use in monitoring is not the direct, is not a very good way of showing what the physiological change that's happening in the body. So one of the common things is, if you have a hemorrhage or a blood loss during the spine surgery, normally what the body does is it constricts the splanchnic blood vessels and diverts the blood to other areas of the body where they need more blood supply. And somebody even looked it up and tried to bleed about 25% of the intravascular volume, and there was no change in the heart rate or the mean arterial pressure, and the only one that was significant was gastric tonometry, which was responsive. We have been looking into this one. We have never used it, but this is one of the finger cuffs which measures the blood pressure, cardiac output, hemoglobin, and the oxygen. And with this one, you can measure the stroke volume and the stroke volume variation and see if the patient is really responsive to fluid. And So I think I'm running out of time a little bit on Exparel. We have also been using Exparel quite recently and having really good effects. And we are doing a full study. And as you know, Exparel is basically bupivacaine in a liposome, and it is known to have a good pain control for a period of 72 hours. And one more thing, post-operatively, early feeding, early liquid diet, solid diet, and early mobilization with the physical therapy as early as 2 hours, and discharge planning rounds. Some of the people have also advised the patients to use chewing gum about 3 to 4 times, and it has increased the gastric motility. And one of the studies showed that it reduced the ileus from 51 to 43 hours after some abdominal surgeries. So thank you.
Okay, the next talk is entitled